I'll be talking on cataract surgery in post-refractive surgery and extremes of axial length. So in the scope of the topic, we'll cover post-refractive surgery, cataract surgery, cataract surgery in eyes with high myopia with an axial length greater than 26 millimeter or minus 6 diopters of myopia, and cataract surgery in non-ophthalmic or extreme degree of hyperopia. So what is the problem in a post-refractive surgery cataract? The most important problem is biometry, because in biometry we consider the flatter cornea as the K reading and put it in the biometry machine. The biometry machine calculates it accordingly and we land up with surprise. In myopic patients we land up with hyperopic surprise, and in hyperopic LASIK patients we land up with myopic surprise. Why so? Because while we are doing a refractive surgery, in especially LASIK, we are changing the ratio of the anterior is to the posterior surface. There is something called keratometric index, which is 1.3375, which changes. So the biometry machine doesn't know that the patient had a refractive surgery done. It calculates and finds out the corneal K value according to that particular index, but the ratio has already changed. So the error happens. So to deal with this, we have newer formulas like Barrett True K, Haig's L, and Holliday report. And you can get a window in AACRS website. They have a post-refractive surgery IOL calculator in which there are three options: prior myopic classic PRK, prior hyperopic classic PRK, and prior RK. But in post-RK cases, many a times we find grossly irregular astigmatism, 16 to 32 cuts, apical scarring, difficult incision location, RK marks are sometimes give away, and there is biometric surprise. So in post-RK cases, it's not always possible to get the lens value from the ACS IOL calculator. It's better to go by Macul algorithm. What is that? We make the patient aphakic in the table and then send the patient for refraction, take the spherical equivalent, multiply with 1.75 to 1.75, sorry, 1.75 to get the IOL power. And proper counseling is a must, because even if you do a lot of things, you might land up with surprise. Tell the patient beforehand that you might have to go for an IOL exchange. So in that case, your lens needs to be changed and a fresh lens has to be put in, so that the patient has to be primed beforehand. So this is one such RK patient in which the cuts are almost very clear cut. So in this kind of a patient, you don't have any problem with biometric calculation. But the thing is, when you are putting the main incision, you might not find a gap between these two cuts. It cannot be, if it's more than, if the gap between these two cuts is less than 2.2 millimeter or 2.8 millimeter, you have to go for a scleral incision. The rhexis has to be adequate so as to overlap the lens, because that's very important. Otherwise, you might develop PCO later on. And as you know that in myopic patients, if you do a YAG capsulotomy, the chances of RD increases manifold. So at every point of time, you have to respect the anterior chamber depth. So while coming out, you must inject viscoelastic so as not to create any kind of posterior vitreous detachment. And then I will in the back. So in myopic eyes, the issues biometry, lens choice, anesthesia, capsular rhexis centration, and dealing with LIDRS. So in extreme degree of myopia, we have seen that only Barrett and Olsen, these are the two formulas which give consistently good results across all the axial lengths starting from 21 millimeter to 28 millimeter. And also there are sometimes huge staphylomas which often gives erroneous results, and you must be very careful. In fact, sometimes you need to do an ultrasonography to exactly locate where the macula is and calculate that axial length manually and put it in the biometer. There is something called Kane formula, which was developed in the year 2017 using 30,000 highly accurate cases. The formula is based on theoretical optics and incorporates both regression and artificial intelligence. The Kane formula maintains its accuracy at the extremes of axial length, resulting in a 25.1% reduction in absolute error in long eyes, more than 26 millimeter, compared with the SRKT, and 25.5% reduction in absolute error in short eyes, less than 22 millimeter, compared with Hoffer Q. So if you can use Kane formula, you will get more accurate results in extremes of axial length. Kane formula is available online. So the choice of IOL should be such that your target refraction is around -1 to 1.5, especially if there is in macular pathology, because if you make a highly myopic patient with macular disease emmetropic, you will find very difficult to see the near. So it's better to keep the patient slightly myopic. And the IOL material should be extremely biocompatible and which has time tested for less PCO should be used, because as I have already told that TIA capsulotomy has catastrophic complications like RD in post-myopic cases. Topical anesthesia is preferable to avoid retrobulbar, to avoid retrobulbar and peribulbar anesthesia, which has the consequent risks of perforating the globe. You should do a topical anesthesia. The rexis size must be adequate, as I have already told, and the lens should be perfectly centered. Flax may be helpful in those cases. There is something called LIDRS, that is lens iris diaphragm retropulsion syndrome, in high myopic eyes when you are entering the phacoprobe, entering the anterior chamber with your phacoprobe due to weak zonules and thin posterior capsules and partially liquefied vitreous. The whole bag, whole lens zonule complex goes down, and in those cases you need to lower the phacoparameters, and sometimes you might need a second instrument to prevent that. So this is something which happens in highly myopic eyes. You can see that the anterior chamber depends, and it depends to such an extent that the iris periphery almost becomes invisible. You use a second instrument to equalize the pressure between the posterior chamber and the anterior chamber, and the whole thing again becomes normalized. So again you need to put viscoelastic while coming out, and that's very important. So IOL can be delivered under BSS, and after injecting the IOL and positioning it in the bag, again you should not switch off your irrigation, dial the lens in position. Aspirate all the viscoelastics. So you have to keep your irrigation on while hydrating the wound so as not to allow the anterior chamber to collapse. So if you are not particularly careful, sometimes you tend to forget that you have a myopic patient under your table. Say this is a Centurion machine which have the active fluidics, in which I have kept the IOP low, so there is no LIDRS that is happening. So the anterior chamber is very stable without any fluctuation. So now if you suddenly come out, so you can see that PVD has happened. So you must be very careful in myopic patients. You must not allow your chamber to become shallow. Now coming to high hyperopia and non-ophthalmos, Holiday 2, Haigis, Hoffer Q, Olsen, Barrett, Kane, which incorporate additional data such as white to white measurement, refraction, anterior chamber depth to produce more accurate results. Cataract surgery is challenging in these eyes because these are small working space, which increases the risk of damaging the intraocular tissues. Uveal effusion may occur more easily because of inherent scleral thickening, which can be detected in UBM prior to taking the patients for operation. And to avoid these complications, maintaining a stable anterior chamber intraoperatively is very, very critical. So there are three types. One is simple microphthalmos, in which the axial length is less than 21 with a normal ACD, normal scleral thickness, without anatomical malformations can be non-ophthalmos, short axial length less than 21, with shallow anterior chamber less than 2.2, and thickened choroid and sclera more than 1.7, but with no other anatomical malformations, and relatively anterior microphthalmos, in which there is normal anterior axial length, shallow anterior chamber less than 2.2, and normal scleral thickness without other anatomical malformations. So we must be very careful with those cases which have increased scleral thickness. So the operative considerations are endothelial protection. You must use preoperative mannitol, which decreases the chances of uveal effusion. You should avoid pressure fluctuations. You might need pars plana vitrectomy in some cases. And in hyperopic cases, the capsulorhexis is prone to tear towards periphery. Refill the anterior chamber with OVD as necessary. IOL choice is sometimes limited. Piggybacking may be an option, but you must use two different materials for piggybacking, or you have to resort to custom-made lenses. And regarding the surgical part, I have already told that you have to maintain the anterior chamber, and that is the mool mantra, and nothing specific. But if you are anticipating choroidal effusion, then you have to do a sclerotomy either by yourself, or you have to refer to a VR guy who will do the thing for you. Thank you very much.